Is the Our next speaker is Dr. Manish Shah, is the Director of Gastrointestinal Oncology Program here at Weill Cornell Medicine, Chief of Solid Tumor Service, and Co-Director of the Center for Advanced Digestive Disease, New York Presbyterian. He will be talking to us about immunotherapy, thinking outside the box, and the clinical trials at Weill Cornell Medicine.
Great. And I think, Deanna, you have the slides for this one.
Are you guys seeing the slide?
No.
Okay, let me stop sharing and share again.
While we're pulling up the slides, I wanted to thank Alessandro and Dorna for setting this conference up. This is terrific. We should do this every other week, I think.
So has anybody seen the slides? Because I'm saying,
Yeah, we're seeing it now. Yeah.
okay.
Will you be, I'll just ask you to go to the next slide. Is that how we'll do it?
Yes.
Okay. So we're talking about immunotherapy, and I think Josh gave a very nice overview of some of the localized data for mismatch repair deficiency, but I'll integrate this with regard to some of the trials that we have here and what we have planned as well. Next slide. So this is a trial of pembrolizumab versus chemotherapy in the first-line treatment setting for mismatch repair deficient colon cancer. And I think the history of this is actually dates back about 10 years when the Hopkins group actually looked at pembrolizumab in a tissue agnostic fashion for mismatch repair deficient tumors, and they had a high response rate, and that led to the first ever FDA tissue agnostic approval of a drug. And what I mean by that is that up until then, drugs were approved for certain diseases for certain indications, but they approved pembrolizumab for all mismatch repair deficient solid tumors based on the trial that they ran. And then they followed that trial up with a first-line trial of pembro versus chemotherapy for mismatch repair deficient colon cancers. Next slide. And the updated analysis is actually here, and it basically shows that, I guess, two things. One is for the control arm, which is the chemotherapy arm, it's the one in orange. You can see that there's a 50% 5-year survival rate, and that's typically better than you get with chemotherapy alone. And of course, the reason why is because the FDA had already approved immunotherapy after first-line therapy, as I had indicated. So patients who progressed on chemotherapy went on to pembrolizumab, and they had a sustained, good outcome. And I think this is what we're seeing in the real world. So that there is about a 50% rate of benefit of immunotherapy in mismatch repair deficient tumors in the metastatic setting. The red arm is when you start off with immunotherapy and not doing chemotherapy initially, and it's better. You see the curves beginning to split at about 12 months, and at 3 years there's about a 10% improvement, and this is again overall survival, not progression-free survival. And at 5 years you're at about 60% survival versus just under 50%. So I think, I've thought about this for a bit. There's other data when you're thinking about targeted therapies that it's not part of this talk, but for example, recently encorafenib is approved for BRAF mutant colon cancer in the second-line setting, and then the Breakwater trial in the first-line setting was published just this summer, and the benefit even seems to be better. And I think that part of the theme is that if you have a target, if you hit the target early, you are likely to do better. And Yeah, that makes some biologic sense too, because the idea is that, if you wait until second line or third line to use the target, other mutations could develop over time, leading to some kind of resistance. So, if you have a target, you hit the target early, you might do better. And I think that from an immunotherapy standpoint, if you have mismatch repair deficiency, you need to start off with that if at all possible. Next slide. And then the Heinz, Lenz, and the Bristol Myers study group looked at IPI and NIVO, which is dual checkpoint inhibition for mismatch repair deficient tumors. Next slide. And this was a 3-arm study of Nivo versus chemo versus Ipi-Nivo. And Nivo, for all intents and purposes, is almost identical to Pembro. There are no head-to-head comparative trials, but when they're examined in the same population, they look very similar. And so this is also really quite important data because it tells us, one, it's kind of a confirmatory first-line study, but two, it asks whether or not dual checkpoint inhibition is better. Next slide. So this is really quite remarkable. This is progression-free survival for mismatch repair deficient tumors. If you got chemotherapy, you're on the gray curve on the bottom. So at 12 months, at 1 year, only 22% of tumors have not progressed. And at 2 years, 11% of tumors have not progressed. Alternatively, if you receive Ipi-Nivo, about 20% of tumors at 1 year and 25% of tumors at 2 years have progressed. It's such a, I mean, you could drive a truck through those two curves. So almost there's no question that Ipi-Nivo is better than chemotherapy, but almost certainly better than Nivo alone as well. Next slide. So this is Ipi-Nivo versus Nivo, and you see a significant improvement in outcome. So I think this reinforces the same point that if you have a target, you should hit it early. Immunotherapy works really quite well for mismatch repair deficient tumors, significantly better than chemotherapy, and the dual checkpoint inhibition is probably better than single. And so I think that's really kind of our standard in the med-onc group here to consider this. Next slide. So, uh, you know, we're seeing that not everybody responds. Although the response rate is terrific, not everybody responds. And so we are opening here at Cornell a trial that looks at this WRN inhibitor. So the concept again is on the left. If you get immunotherapy, single agent PD-1 therapy, about a 50% survival. And so about half the patients, they have some underlying built-in resistance or they develop resistance. And so next slide. WRN is it's a helicase that is important in mismatch repair deficient tumors. What it really does is it unwinds the DNA and allows for repair. And mismatch repair deficient tumors are very, very sensitive to this helicase being present. So the hypothesis is that, the mismatch repair deficient tumors, some of them may be resistant because they have good activity of this Wernicke helicase, WRN helicase. Next slide. So Amgen has a drug that is a inhibitor of WRN, and so the study is essentially a phase 1 and phase 2 study of this Amgen 436 WRN inhibitor plus immunotherapy in mismatch repair deficient tumors, including colon cancer. So we'll be examining that. There's a cohort that for patients who have progressed on first-line immunotherapy, it'll be very interesting to see if adding a WRN inhibitor will overcome that resistance. And our colleague, Dr. Mehta, will be running this study. Next slide. So for mismatch repair deficient tumors for metastatic disease, immunotherapy is standard. I think we would lean toward ipi-nivo if we think the patients can tolerate it, and we are examining one of the potential mechanisms of resistance to immunotherapy with this WRN inhibitor. Next slide. So Josh went through this data already, so I'll maybe go through this pretty quickly. This is the MSK study, which I think was very well designed. It looked at immunotherapy, dostarlimab, and then if you didn't have a clinical response, you were able to get chemoradiation and then surgery, kind of like a modified TNT approach. It turns out nobody required that arm because everybody had a complete response. Next slide. And these are the data that were published previously. And as you heard, the updated data are still, everyone has a clinical complete response. Next slide. The niche study, Josh mentioned this previously, was examining immunotherapy in mismatch repair deficient and proficient tumors. Next slide. And they did a niche 2 trial, which was published in the New England Journal of Medicine, which is really, really quite remarkable. For localized disease, mismatch repair deficient, you get 2 doses of immunotherapy. You get ipi-nivo on day 1, you get nivo on day 15, you have surgery at day 28 to day 35, and you have a 95% chance of a major path response. The patients with a major path response, none of them have had recurrence so far. And in fact, next slide, none of the, I didn't put it here. The Kaplan-Meier curve, if you go back for a second, if the Kaplan-Meier curve shows that the 3-year disease-free survival is 100%. So no one's had recurrence on this trial so far. I didn't put it in here because of time constraints, but the Atomic trial was presented at ASCO as well. This is for mismatch repair deficient tumors that undergo resection, and FOLFOX plus durvalumab is now standard, significantly better than FOLFOX alone. But in that trial, the patients who got immunotherapy, they had a 3-year disease-free survival of 80%. So still not as good as this study. And I think it gets to the same kind of theme. If you have a target, it's better to hit it early, even in the neoadjuvant setting. I think that's kind of what we're observing. Next slide. So for rectal cancer, immunotherapy is standard for localized MMR deficient rectal cancer, and for localized colon cancer, immunotherapy is standard, certainly in the postoperative setting. And I think, there's a lot of data that supports its use in the neoadjuvant setting as well, even without a clinical trial. So, this is something that we've worked on. Dorna has kind of led the efforts, but we want to come to alignment on kind of how we think of these tumors, because the other part of the early stage setting is that if you have a stage 1 or stage 2 colon cancer, surgery alone is curative in over 90% of patients. So, is there a downside to doing 2 doses of treatment and then surgery for everybody, or should we try to be selective? And I think we need to figure that out through our disease management team process. But the data are exciting, and practice is changing already for mismatch repair deficient tumors. But of course, that's only 10 to 15% of early stage disease and 5% of metastatic disease. The vast majority of patients with colon cancer are not mismatch repair deficient, and in that setting, we ask the question, can immunotherapy work? Next slide. So Pashtun, while he was here, led the NEST trials, and we're now kind of putting this together and thinking of like next steps here. So BOT and BAL are 2 immunotherapy agents. BAL is a PD-1 inhibitor, balstilimab, similar to nivolumab and pembrolizumab. Botensilimab is a CTLA-4 inhibitor. It is similar to IPI. So you think of dual checkpoint inhibitor Ipi-Nivo, it's similar to BOT/BAL. And just go back one, sorry. Um, and this study looked at the efficacy of BOT/BAL in both mismatch repair deficient and mismatch repair proficient tumors. Now, the niche trial looked at Ipi-Nivo in about 15 patients, and the major path response rate was around 20%. 3 out of 15 had a major path response. So it has modest activity. And again, in the metastatic setting, Ipi-Nivo has less than 5% activity. So again, hitting the target early probably makes a difference. In the neoadjuvant setting, I think there's some, mechanisms of resistance that colon cancers develop when they develop metastases, and I think we're trying to understand that. But so in this space, where you have microsatellite stable colon cancer, non-metastatic, immunotherapy has some hint of activity, and we wanted to examine this in MMS, I mean, mismatch repair stable localized colon cancer. Next slide. So these are the data all combined. The NEST-1, there were 7 mismatch repair proficient tumors, and in NEST-2, they're slightly larger. There were 14 mismatch repair deficient, proficient tumors, and the major path response rate was 40%, 41%. So a little bit better than Ipi-Nivo, and that led to a yeah, you can go to the next slide. That led to sorry about the, I don't know what happened here, but essentially the MPR rate is 9 out of 22, 41% between NEST-1 and NEST-2, and then there were a few patients who were mismatch repair deficient, and it was essentially 100% major path response rate, similar to the niche experience with Ipi-Nivo. So the difference between BOT and ipilimumab is that the antibody is Fc modified, such that the antibody is stickier. It increases the synapse between the antigen presenting cell and the Treg, and by doing that, it is intended to deplete Tregs more. So we think that kind of this maybe step up in immunotherapy efficacy is because of depletion of Tregs. So that's kind of what we think is going on here. There is a improvement in major path response. Agenus, that owns both of these drugs, they are moving forward with developing BOT/BAL in the metastatic setting, in the salvage setting. They actually, I just found out, they're running a large 800 or 900 patient study of BOT/BAL versus best supportive care in the 3rd or later line setting for microsatellite stable colon cancer, and this is through the NCI Canada cooperative group. Next slide. And this is our progression-free survival on the NEST-1 and NEST-2 studies. This is actually now updated. We have a median follow-up of 18 months. NEST-1, the follow-up is 27 months, and NEST-2, the follow-up is 18 months. So and no one has had recurrence so far, which is I think it it is notable. Next slide. So we are about to launch a new trial looking at next generation immunotherapy agents for localized colon cancer, trying to build on our experience with BOT/BAL. Next slide. So HLX43 is a PD-1 inhibitor, but what makes PD-L1 inhibitor, but what makes it interesting is that it's actually an antibody drug conjugate. So linked to the antibody are these small molecule camptothecin drugs. It's the payload. So you think of it almost like a Trojan horse. The antibody is delivering, is binding to PD-L1, which is on antigen-presenting cells on tumor cells, and you can see the mechanism on the right. It gets internalized, and the drug, the camptothecin, actually gets released within the cell and the tumor microenvironment, and it can kill those cells. And you might think, well, that's not a good thing, but in fact, I think it's a good thing, because you do want to kill the tumor cells that are expressing PD-L1. You do want to kill the antigen-presenting cells that are expressing PD-L1, because PD-L1 is the ligand for PD-1. So by reducing PD-L1 expression, you reduce the inhibition signal of PD-1, and you can activate the immune system while also killing the colon tumors. Next slide. The other drug that we will be examining is serplulimab. This is another PD-1 antibody, and this is a trial that was done in China looking at chemotherapy, Avastin plus or minus serplulimab. And if you receive serplulimab, it looks like you are having some benefit in the metastatic setting. So the desire was to examine this PD-1 inhibitor as well in the neoadjuvant setting. Next slide. And this is the microsatellite stable population. So 17 months versus 10 months. So it is actually looks like an interesting combination. Next slide. And so serplulimab is the drug. I thought this was really fascinating. So this is the binding site on PD-1, which is the ligand on T cells. So pembrolizumab binds where the blue is. Nivolumab binds in a different area. So, although we think of pembro and nivo as the same for all intents and purposes, they do bind differently. So you could imagine where one drug could work and one doesn't because of some, mutation alteration. And HLX10 kind of binds in both pockets, both the central pocket where pembro binds and also on the superior surface where nivo binds. So the company actually thinks it may be better. I don't know if it's better, or it may take 10,000 patients to show that it's better, but that's it. It is a different drug. It binds in a different way. Next slide. So this is our clinical trial. It is a little bit complicated. The cohort A, so cohort A, cohort B2, and cohort C are all neoadjuvant for microsatellite stable colon cancer. Um, all three of those arms are evaluating a novel immunotherapy combination. Cohort A is looking at HLX43 alone. So again, that's the PD-L1 antibody drug conjugate, 2 doses and then resection. Cohort B2 will evaluate HLX43 plus IPI, the CTLA-4 inhibitor, which is intended to deplete the Tregs to a certain extent. And the cohort C is HLX10 plus IPI, the serplulimab, which is the other PD-1 inhibitor that the company is looking at. So we are going through the approval process. I'm hoping that this study will open in the next few months, and we'll be able to enroll, to this trial. Next slide. So I highlight here the clinical trials we have for immunotherapy in colon cancer. Actually, I neglected to mention another trial that we will be opening maybe 6 months from now. It's an ETCTN trial for colon cancer that's ctDNA positive. It would be using BOT/BAL in the adjuvant setting in that trial as well. So we'll have several trials to look at immunotherapy and colon cancer here at Cornell, and I think it's really an exciting time. Immunotherapy has been transformative for lots of tumors, and hopefully we can apply it to more tumors for colon cancer. I think that's all I have. Next slide. Yeah.
Great, thank you, Dr. Shah. Again, the panelists, feel free to ask any questions. I'm going to start with one. What is, granted the magnitude of surgery between a colon resection and rectal resection is completely different, but what is preventing us from offering non-operative management for colon cancer. What are the steps that need to be taken?
I'm so glad you asked that, because as we're putting together the NEST 1 and 2 paper, I was thinking the exact same thing. I mean, so I didn't mention this, but uh, kind of putting it all together, it turns out that if you have a BRAF mutation or a KRAS G12D mutation, and these are mutations that are associated with a more immunosuppressive microenvironment. These are actually the tumors. None of those tumors, and we had 3 or 4 of them, none of them had a response to BOT/BAL. So if you exclude those tumors, your major path response rate is actually 50%. So I think now we're approaching an area where we could have a situation where you have a high enough rate of major path response that we could think about a watch and wait approach. And in fact, I think we should have a discussion on how we do this. I was, the other thing is, like, I think unlike rectal cancer, for colon cancer, we don't have great imaging for response. And I think in our experience with BOT/BAL initially, and Dorna can talk to this, tumors that had a major response, often they still had a big, huge, bulky mass that was inflammatory. So you can't tell. If you repeat the colonoscopy, like there's an image of a major tumor that actually had a major response, just visually. But I was wondering, and so the other thing I should mention is that um, the tumors that have a major response have pathologically this finding of tertiary lymphoid structures. These are small little nests of B cells and T cells, and kind of in the periphery of the tumor, and this is where we think some of the immune education is happening. So one idea that I had was, kind of designing a trial where before surgery, repeat the colonoscopy, do a kind of a deep biopsy, look for TLS, and if you identify it, then maybe you have enough evidence because visually it's not there, and pathologically you see more TLS, that maybe you consider them as a clinical complete response that you could watch and wait. But this is something that I've just only been thinking about only because this manuscript is in development, but it's something we should think about together, how we can do this.
Great. That's great. We also discussed at our tumor boards and stuff the idea of offering immunotherapy to all MMR deficient tumor, irrespective of stage. And we didn't really need reach a consensus. What is your take on that?
I'm sorry, what was the question?
Offering immunotherapy to all MMR deficient tumor, irrespective of stage.
Yeah, I mean so I think we need to think through that as well. I mean, number one, I think that we as a group, Upper East Side, Brooklyn, and Queens should be aligned on how we manage these patients. And I think that I think that so I think if you see the tumor radiographically, I think there's no disagreement that neoadjuvant ipi-nivo, if the patient's a candidate, should, it probably is a good thing, because after 2 cycles in surgery, the cure rate seems to be so high. So I think that seems to be agree, everybody agrees on that. I think the question is, if you don't see the tumor, and if you don't see the tumor, there's like a 80-90% chance of cure just by surgery alone. And that's what you're going to do anyway. So then is it worth the toxicity, low as it is, of 2 doses of immunotherapy? I think that's where we need to come to alignment on.
Great. And in terms of assessing response, you didn't touch of ctDNA, but we have a talk in an hour that will tell us all about that. So I will not ask you that question. Dr. Jafari in the chat mentioned that she's in favor of offering immunotherapy to all comers. she said, yes, I believe so. If you want to comment
I
on
don't
that.
remember responding to a chat, but yes. I mean, I don't know. I would take it with a stage 1. If I had a 10% recurrence rate, I'd take it. So if I take it, but I'm not the one who's giving it.
But don't you lose? But then you lose the opportunity of having it if something comes back. Is my only thought. Or later
No,
down.
because it
No, you
works
don't.
best when the tumor is there.
Yeah.
Well, so far no one's come back. I think the real. I mean, all right. So you know, treating patients on the different trials that we have, and it's rare as it is, but for example, on Encusa's Panther trial, which is a wonderful trial, you know, there are some patients who have adrenal insufficiency, and then to counsel them to say that you have to have a bracelet for your whole life, and you have to take hydrocortisone for your whole life. It's like, it's not so easy. Or your thyroid is messed up for your whole life, or whatever, or your adrenal insufficiency or something. I mean, it's just it's the toxicity rate is low, but it's not zero. I think the real question is there really benefit in that stage 1 group? And does it outweigh the risk of toxicity? I think that's what we have to, and I think actually I could go either way. I just want us to do it the same. I think that's the important part.
I think the issue is that we can't really tell if someone's a stage 1 just because there's no tumor on the scan. That's the issue, because it could be like a very small tumor with positive lymph nodes for colon. And then the question becomes, if you had a low rectal cancer, T1 and 0, MMR deficient, would you give that person immunotherapy? And the answer is yes, but the surgical ramifications are higher.
A little bit different.
And I'm not the one having those conversations, so it's very easy for me to be like, Manish, just give him something.
But we should, so there, this must have been done, or we should do this. So we should have a cohort of 50 patients where we have colon cancer, but it doesn't show up on a scan. And what is their stage? I think that the rate of being T1N1 on those scans is probably way less than 5%.
Yeah.
I mean, we can even do that retrospectively. We have the patient.
Yeah, we should just look at that, because then that would help us guide, you know,
Our decision making.
Well, the opposite happens every once in a while as well, where you see something, bulky lymph nodes on a scan, and you go into surgery saying, I bet there's going to be something. You take out these big lymph nodes that you can see, and it ends up being node negative.
They're all node negative, yeah. So but for those, I'm okay giving immunotherapy to, because, you know, maybe a third of the time they're really positive. I struggle. I mean, that the honest struggle is the risk of toxicity in a highly curative option for the early stage cancers.
Yeah, and I'll just add, you know, I think we need more mature data until we kind of can make confident decisions with immunotherapy. I think kind of having conversations with our patients, risk benefit, is very important. I know Dorna and I have had several patients kind of MSI high, but they're, you know, elderly, frail, kind of poor surgical candidates. I think that's a great, you know, avenue where we can introduce immunotherapy, kind of low toxicity. Obviously not the majority of our patients, but I think there's definitely a role for the right patient.
I think blood-based biomarkers also will help as it gets better. The issue is if they're ctDNA negative, you really don't know. So if they're positive and you can't see it, like, so there's like different algorithms I think you can go with, and I think our technology is getting better. But at the same time, if you have an ileocecal valve lesion and you give immunotherapy, sometimes those patients can get obstructed from the immune response. So I think there's a lot that we don't know, and that's what makes this very interesting.
And we've also seen some cases where we see this inflammatory kind of milieu, and we don't necessarily know, we assume they're responding, but we don't know radiographically with certainty. So, you know, it definitely poses challenges.
Yeah, I hate to interrupt this discussion. This was a good sample of how we discuss our patients at tumor board on Thursday evening. And we can stop the recording. Thank you, Dr.